it, to remove it, they can use an NG tube. It can be placed in surgery at the bedside. It can just be used for surgical purposes. So a lot of patients, if they have surgery on their stomach or something, they could put an NG tube, and it will help the surgeon to identify where the stomach is, and because they can actually feel the tip of this in the stomach. And also to keep that airway or that pathway patent. So when you do the NG tube skill, you need 4 items, and it will all be on the cart. And we will be testing back in that area. So you would want to grab a kit, and here it has all the supplies for the NG tube insertion. You need to grab a suction cord, the tubing, suction tubing, this vacuum device that you connect to the wall, and an actual canister. So you need these 4 components. Now, for the NG tube, it's most commonly referred to as the Salem sump tube, and that's what this is. They can come 14 French, 16 French, 12 French, and I believe 18 French. Okay, standard would be about 14, 16. They go based on how big the nair is and how much fluid do they really need to bring out, pull out. You think of a 12 French, the little holes will be even much smaller. 12 French can be used on a very small person, a child, and it doesn't hurt as much. This is a 14 French, I believe. Now, the Salem sump, this has 2 openings, so you can see how there's 2 different ways that stuff can go in. We use the big opening, but there's 2 different holes and ports. This here is to always just block it off. So your NG tube can be connected to suction or not connected to suction. It's all based on the doctor's order. Now, for testing purposes, you will all connect to suction, so you know how to actually connect it to the wall. And hopefully the vacuum works so that you can set it from continuous versus intermittent suction. Now, for this, when you anchor, when you pull this out of the package, this is a clean procedure. It's not sterile. You just have on clean gloves. You want to make sure that this is closed like that, because as you insert, if they have a lot of fluid in their stomach, it's going to immediately come out and it'll leak out onto their gown and stuff. So you just want to block it right away. So you just do it like that. All right. Also, for your NG insertion, you always want to assess your patient. You want them in what type of a position? High Fowler. You want them sitting all the way up. And for the skill, whatever side you're on, make sure you have the side roll up on the opposite side for safety. Now, for the assessment, you want to assess the nair. You want to assess the nairs to see if they have a deviated septum, if they had a broken nose before, or if their natural anatomy is where it's crooked. You want to go on the straighter side, the side with the least resistance. You also want to check for error. Yeah, so those of you back here may want to move this way. So, and you also want to check for the nair that has the greatest airflow. And you can just do that by obstructing the nair, telling them to breathe out. Do it on the other side, and you do on the side that has the best airflow. So that way it's not getting clogged. Also, if they have allergies and sinuses, a lot of drainage, kind of want to go on the one that is least blocked. You can also ask them, have they had a history of having an NG tube before? If so, which nair do they prefer? They can tell you. They can be, if they're a good historian, you can go based on what they've had done before, and you just follow the same thing. You can also do an oral assessment. You just look in the back of their throat. And some of these kits have the tongue blades. For the skill purpose, you don't have to pull it out and use it. It's just that it is part of it in the hospital. You want to make sure that open your mouth real wide. You can look in the back of the throat. Because as you're advancing the NG tube, you want to make sure that it doesn't coil in the back of the throat, because they'll feel like they're choking. And that can occur. So you want to make sure that when you insert and go in, that you're able to see the back. And you should see it go right down into the esophagus. It'll go right behind the uvula. All right. Also for assessment then, some patients will vomit when you do it. That's normal. You just have to keep going for it. It all depends on the patient's tolerance for it. Because you are bypassing the gag reflex, that's where you get all the resistance, the complaining, the yelling. Again, you're just having to go, brace yourself, go for it, and you do it pretty much when you know that you've gotten past the back of the throat, the gag reflex, you go for it. You go as quick as you can to get to the stomach. Don't waste your time and slowly go in after that. Now, if a person comes at you with this, what do you naturally do? You go there. That's perfect, because that's how you want to start. You want to start where their head is back. So that's why it's good that they're either sitting up with the pillow behind their head. We had one man who never had an NG before, and he just sat on the side of the bed, and he said, go for it. He didn't gag or anything. I was just like, you were too easy for the student. I mean, I had never seen a patient that was just like, just go for it. Go ahead. No problem. Never seen that before. But just ideally, just on a bed, head up. Now, what I would suggest when you come in and you do the skill, you can either do the IV first and then the NG, or the NG first and then the IV. It doesn't matter to me. You're coming in with an order and you're completing the skill. All right, now, your order for next week, these are examples. I'll pass it around. I'll hand you one of these cards. So on there, it has an order. Either you're going to give Kevsol, piggyback, or you're going to hang normal saline. And then you just complete the skill. It tells you that you're going to anchor a 14 French nasogastric tube. All the nasogastric tubes are based on French size. It will tell you if it's to high, low, intermittent, continuous suction, and you're connecting the wall. Now, yesterday, as some of the students, we had problems connecting, or not connecting, but getting it to read appropriately, like low, intermittent. If you have that problem during the skill, just say it's not working, but I would make sure it was to low, intermittent suction. But all of them will connect to the wall. All right. On the one that says the normal saline, the 0.9% normal saline, it says 30 drops per minute. That is the 1 drop every 3 seconds. So you need to set it at that. 1 drop every 3 seconds. But that is the example card that you will get next week. So what I would suggest when you come in with this, you come in with your NG tube and whatever IV supply that you need, then you want to set up, I would suggest just setting this up so it's off your bedside table. So this screws on to here. So if you get one today, yesterday we pulled the ones that were broken, but if this completely lifts off and it doesn't connect to the tubing, let us know, because it should connect. You should be able to do that. This just screws on. So you just screw those two on. This tubing connects to the elbow. So it connects to this part. You're not opening this and connecting there. You're connecting to this elbow. Now, when you get to the wall, this, you want to go to the vacuum. Not oxygen, not air. You're going to vacuum. All you do, this goes into there. It goes in and it clicks. You should hear a click. And it connects to the wall. If you want, when you want to remove it, you just turn this white to the right, and it will just disconnect from the wall. So you screw that on, and you just connect. And you should hear a click. And then you just take your tubing, and you connect to the elbow. And then what I do is just take this cord, and I just put it underneath whatever, and you're ready to go. So then you can do your IV first, or you can do your NG tube. So then what you would do for the skill, you want to place a mat on your patient, shiny side down, because they can vomit, spit, whatever, it's to protect their gown. This is an emesis basin, so that if they do, you can catch that. So you can put that in their lap. Some of the kits have a cup. That's so that you can offer water to your patient, and some have a straw. If it doesn't have a cup, don't worry about it. You would just verbalize, I would have water available for my patient. And that's so when you tell them to take sips of water, they have it available. If your patient is NPO, you cannot give them water. So you just have to tell them to swallow, swallow, swallow on their spit. All right?
Do any of the samples have NPO on them?
I don't think they do. Do they? Do any of my cards have NPO?
Any of the samples?
I don't think any of them do. No, so all of them you would be able to get water. Yeah. Also, so you have your tongue blade. That's just in there for your assessment. The alcohol and benzoin are for cleaning if you need to clean the nair or anything like that. We don't need that for here. And then you have your lubricating jelly. You will not use you will not actually open these. You will just verbalize, I would lubricate the end of my NG tube. But in the live setting, you must use and open the package. Right? And then you have this little clear plastic device. It's like a connector. This is what connects your suction tube to your NG tube. So it doesn't matter what end goes into what side. You just put it in that end, you pull this blue end out, it connects. That's how your NG tube connects to the wall. You have to have that adapter. Because these two do not fit together. So you have to have an adapter piece. If you notice, we checked all the kits yesterday. They did have this. But if you notice it doesn't have it today, let us know. We're not trying to trick you. All right? So it just connects. That's how you connect. Now, you can anchor it with it already connected. It's up to you. Or you can disconnect it and then do your skill. So I left that connector on there. Then you have a rubber band, safety pin, and you have tape. So now I will show you what we do with these. And then you have a syringe. So this is for your placement verification. So at the bedside, you will use air auscultation, but no more than 30 milliliters of air. And you would verbalize, I would use my stethoscope, and I would listen for gurgling. In the hospital, they can also check with gastric paper if they have it, but now they're not really doing that. So your most reliable verification for an NG tube insertion is an X-ray. So everyone who has an NG tube inserted, either X-ray will come to the bedside or the patient will go to X-ray and they will do take a shot and see where the NG tube is. From that, they will tell you as the nurse, you need to advance it an inch or so, you need to pull it back an inch or so, or you're fine. So your final verification is an X-ray. But at the bedside for anchoring, all you're going to do is the air auscultation. And that's after you have inserted. And when you hear the gurgling, then you connect your suction and you move on. And then they go to X-ray, and then they verify it from there. Even if they get it put in surgery and anesthesia does it, it still has to be verified by an X-ray. So that it takes away the human air, that it's in too far or it's not in far enough. All right, so as far as measurement for an NG tube, how do you know how far to go in? So you have little holes along your the opening of the NG tube, and then you have markings. You see the black markings. So this can help for measurement. After you measure, if it lands there, then you know you need to advance that far. If not, then you advance that far or this far. So it's just landmarks for you. But you always want to measure. You don't want to just say, well, based on your height and weight, I'm just going to go here. You don't want to do that, all right? So you do want to measure. Now, our mannequins have, their chest is a lot higher, so you will not go in as far. But you still must measure and mark. But do know you will reach a point of resistance before you get to the mark, and that is fine. I just still need to see that you have marked, and I will show you how to mark the tubing. So to measure, you go from the tip of the nose to the bottom of the earlobe, from the earlobe to your xiphoid process. So everyone touch their xiphoid process. Everybody know what I'm talking about? Yeah. Now, depending on the mannequin, you may have to guess a little bit. All right? So this one has a wound, so I'm going to say about to here. So it's about the lower part of the mannequin's chest. So we want to make sure everyone can see. Let me move this forward. So you go from the tip of the nose to the earlobe, and from the earlobe to the xiphoid process. Same way over here, tip of the nose, to bottom of the earlobe, and then from your earlobe, xiphoid process. So you find that you see where you are. If you're in the hospital and you have a black marker, you could just take your black marker and create another hash mark. Or you could just take some tape and then you would just go around the tube. So this is how you know you need to at least go to here for your placement. And then when you reach this point in there, you stop, do your air auscultation. You hear the gurgling, you're good. If you don't, maybe go in a little bit, or if you still don't hear, pull out a little bit. It's like a little game until you can hear the gurgling. And then it's based on X-ray from there. So you have your marking, and then you would just tell the patient, okay, when I tell you to take a few sips of water, then I'm gonna. That's when I need you to take some sips for me. So you have your basin nearby, you have this set up, and you would verbalize. I would lubricate the end of my NG with the KY jelly. Before you lubricate, when you get it out the package, these aren't as stiff because we've been using them over and over. They're very stiff. So you just want to roll it around your 2 fingers just to soften it up, and it makes the tip of that just a little less rigid. So you just kind of want to roll it around your finger. All right. So you go from the tip of the nose to the earlobe, and then from the earlobe to the xiphoid process. All right, and I have my marking there. So you go at the patient. You can either put your hand on their shoulder, just kind of help brace them, and you're just going to go in. Now for the skill, you decide what side you want to go on. If you want to do it on the left side of the patient, go right ahead. Doesn't matter to me. So whatever side you feel comfortable with. So you would tell the patient, okay, tilt your head back, and they're going to naturally do it because you're coming at them with something that they don't want to be done. So you go in, and you're going to start hearing gagging and everything, and you keep going. You have your emesis basin here. You can hand it to them. And this is where you want to look in the back of the throat. And you should be able to see the NG tube actually in the back of the throat. And once you see that, you're like, okay, you're past the hard part. Once you get past the gag reflex, you're fine, because then they don't feel it. But if it coils in the back of the throat, then you would pull out a little bit, and then you would go right back forward. The last thing you want to do if you see it coiling in the back of the throat is to pull it out all the way and be like, okay, let's do it again. Do not do that. So even if it coils in the back of the throat, you just pull it out. Even if it's still to the tip of the nose, you do not take it out all the way. Just be like, okay, just calm down. It's okay. Do not take it out all the way. Once you do that, they can say forget it, and then you've lost it. All right? We're going to try this again, and you just keep going. And once you see that you've gone past, you're like, you know what? You're good. You're good. Okay, now this, when you make it past the gag reflex, okay, tilt your head forward, and this is where you can help them. Tilt their head forward. Now take some sips of water for me, because you're good. We've made it past a difficult point. And this is where I have stopped. I've met resistance in this mannequin. So you can see there will be a big gap. But you see my marking. This is where I would normally go on a live person. So what you do, and see I left this open. So if he had fluid, it would be coming back and leaking out. So I didn't close it. All right. So as far as placement verification, you can check for placement now, or you can anchor it and then check for placement. It doesn't matter. Just check for placement before you leave the bedside. Because once you leave the bedside, you'll forget. And then you've never checked to make sure. All right, so I'm going to check after I anchor. So I've got this capped off. So to anchor it, you take a little bit of this silk tape, and it's silk tape because it's more gentle on the skin. And you just take a piece and you put it across the bridge of the nose. You take another piece, and if you want to take your gloves off when you do this, it's up to you. I'm good at doing it. I'm used to doing it with gloves on, so it doesn't bother me. Well, that didn't split very well. You want a Y. All right. So you want to create a Y with your tape. So you're gonna come here, let me take your mic. All right, so you're just going to go across the top the other way of that piece of tape, and you're going to wrap around one way. And then you're going to take this other side, and you're going to wrap around the other way. That's how you secure it in place. And that's so if it's pulling or tugging, it's pulling on the top piece of tape and not all the skin, because the bottom piece of tape is secured to the skin. Then what you can, so now if you want to check for placement, you can. So, okay, I'm just going to check for placement. And if you got some fluid coming back, you have your emesis basin, but you would just verbalize. I would take my stethoscope, place it over the stomach, and I would listen for gurgling sound. Once you hear gurgling, you can stop. So no more than 30, because you don't want to get them gas and make them start burping. They've got an NG tube in. All right, so once you get that, and you've got placement, now you can connect to your suction. Now, the last thing you need to do is secure it to their clothing, because this is just free flowing. Another nurse comes in, trips over it. It's just like it can pull this out. So the last way to secure it to the patient's gown, you want to make sure you give enough slack so that they can turn their head left and right. You don't want it like that because that's too tight. They can't move their head. So you just want to give enough slack. It doesn't matter how much, just enough so that they can turn their head. You can either use this rubber band, you wrap around, and you make a knot. Now, if you're not good at doing that, then don't do that. I'll show you the tape method. Then you would just take this rubber band around the paper clip or the safety pin, and you would just safety pin it to the gown. Now, this is going to hold that so that if someone comes and yanks it, you see how it's yanking from the gown and not the nose. It's going to pull it from the gown first, which will let the patient know, hey, you're pulling on my cord or on my NG. All right. The other way you can do it, if you can't figure out how to do the knot with the rubber band, all you do is just take tape, wrap it around it, and use your safety pin. So you can take some tape. And it doesn't matter how long or anything. There's no rule on that. Just take the tape, wrap it around it, and you go through the tape and your gown. So you have the same effect. So rubber band or tape in the gown. And that's it. Now you want to test out your suction. So on here, you will see that intermittent is up and continuous is below. So you can turn it either way based on what your order says, either intermittent or continuous. This knob regulates the full, high, medium, and low. So that's how you will get to low, intermittent, high, continuous. Now, some doctors, they may say set it to 60 on low, 60 on low suction. Then that is low. Or they can just say set it to low. It doesn't matter where at in low. You could be at 20 in low, 40 in low, 60 in low, as long as it's low. If they say a specific number, then you dial to that specific number. So you would just put this in the wall, and I think yesterday this was only working for continuous. You may have to dial this around and really play with it. There we go. All right, so that's on continuous, and you can see how this dial, it controls whether if it's low continuous, medium continuous, high continuous, and full vacuum. Now, on intermittent, doesn't necessarily work. I won't get the dial to work. But at least you can see this is how you would get it to work. So if it doesn't work for you, if you're trying to get an intermittent or something, just say, I would make sure it was too low intermittent suction, high continuous suction. All right, so if it doesn't work. But at least you can see how the dial turns in. So that is the NG skill. And you want to make sure you can check for placement whenever you want. Just make sure you do it before you leave the patient's bedside. Otherwise, you'll forget. You won't come back and do it. Any questions about the skill? So you can do the IV before or after. If you have the secondary IV, a primary will already be set up. You just connect to it. If you have to do the primary, then you have to do the initial setup. So any questions about the NG? All right, so you can get a kit and practice, and you can also practice